I'm again with a weird topic. So we'll start with the scenario. So this is the scenario which you would have seen before. A 36-year-old female, a history of anxiety and depression, possible diagnosis of irritable bowel syndrome, no medication except oral contraceptive, sudden onset of weakness of right upper and lower limb, clinically normal tone, weak upper and lower limb, no facial weakness, no visual or speech deficits. What are your next steps? How are we going to investigate this? What is the diagnosis? Too many questions. What do you think? It's 5:30, so you people need to wake up. What do you think? Could be a thromboembolic event because she is on OCP. Okay, right. Anything else? So you're thinking it's a cerebrovascular event. Okay, right. So if it is cerebrovascular event, how are we going to investigate? So imaging of the brain, what is your modality? CT, MRI? So CT, okay, CT is normal. What is the next one? CT is normal. Still you think it's a stroke? What do you think? What is the next one? CT is normal, you still think it is a stroke because she has an OCP? Yeah? What is it? What is the next modality? You don't do MRI? Okay, you do MRI. Okay, MRI is normal. Because she said about OCPs, we also did a venogram. That's also normal. Okay, what's the next? Anything else? So normal imaging, what's your diagnosis now? Electrodiagnostic studies. What are we doing here? What are we trying to identify with electrodiagnostic study? We're not talking functional neurology at all. Yeah, what is the next step? So MRI and CTs are normal. You want to do electrodiagnostic study. Why are we doing electrodiagnostic study? I have never said anywhere that it is lower motor neuron lesion. Sorry? Patient wants a diagnosis. And mind you, stroke is a clinical diagnosis. Imaging is only a supportive thing. All the definition on stroke says is a clinical diagnosis. The person has got appropriate weakness. It is stroke. So we can only say that this person has got weakness. Scans have been negative. That's all we can say at this stage. It still could be stroke. That we need to actually look at it further. Okay, right. Okay, now we talk about functional neurological disorders. We'll come to this case again. We will look at it again. So this is the emblem of a functional neurological society. The society was started about 2017, and the first conference had 20 people. And the last conference was about 2 months back in Verona. They had to actually stop the registration because they had no space to accommodate people. So in this many years, 6-7 years, the people's interest on functional neurological disorder has gone so much. It's a truly multidisciplinary society, and the important thing about this society is that the patient has significant say in the activities of the society, the conferences. Last conference had 2 sessions where the patient's advocates and the patient presented their own experiences. So they're actually doing great work. Now, these slides are, I have to actually acknowledge one of my colleagues who did some of the slides here. Okay, what are we looking at? What is functional neurology? Look at pathophysiology, diagnosis, how to discuss the diagnosis, and treatment option. Now, I was actually looking at the functional neurological disorder scenario in India and realized that most of the private hospitals, like all those big chain, Apollo, Max, all has functional movement disorder clinics. But I can't really see a rehab or physical medicine and rehab person involved in any of those clinics. It's all neurology clinics. So all the private setup has got clinics. I don't know what about the government setup or CMC or somewhere where they have any functional neurological, they see functional neurological disorders in rehab settings? Do we?
We do. Occasionally we get a referral.
Okay, right. Okay, right. So, I mean, this is a big part of my work, and I actually see them in my pain, in my rehab. We always have at least 5 or 6 patients in our inpatients, so many patients on our day rehab services going through treatment for functional neurological disorder. We see a lot of people in pain unit. In fact, the neurology admissions, 5% of stroke admissions are actually functional neurological disorders. So many terminologies. I mean, functional neurological disorder is a new terminology. Previously, it was called conversion disorder, psychosomatic disorder, medically unexplained symptom, and hysteria. Hysteria, the word hysteria has been there from many years. It's one of the very early medical diagnoses. When people didn't know what it is, they put it as hysteria. Now, what's the definition? So as we all know, there are 2 types of classification system, DSM and ICD. ICD is pretty rubbish for functional neurological disorder. They don't really talk much about it. DSM has pretty good sort of definition, and DSM-5 actually has improved the definition. The difference is that DSM-5 actually removed a requirement of preceding psychological event, of significant event. So we need to have altered voluntary, motor, or sensory function. Clinical findings provide evidence for incompatibility between symptoms and recognized neurological or medical conditions. The symptoms should not match with recognized neurological condition, should not be better explained by any other medical or mental health disorder, and there should be clinically significant distress or impairment. I bolded all the important words in that definition. Now, what are the common symptoms? Functional seizures, functional movement disorders, more commonly tremors, sensory loss including vision, speech disorders, motor weakness, dizziness, and recently functional cognitive disorders are being more and more diagnosed. Now, in olden times, these 2 are considered to be 2 pillars in diagnosis of functional neurological disorders: inconsistency and incongruence. Inconsistency means the inconsistency of clinical symptoms, and when you distract, the symptoms reduces, and the symptoms, the weakness is variable, and there is difference between voluntary activities. So voluntarily patient cannot move, but automatically patient can move the arms. You have to be careful here, because you realize that some of the strokes, when people are in sleep, they can actually move the hand, but in real voluntary they can't. That's not functional neurological disorder, but you have to be careful in using the inconsistency. Inconsistency, day-to-day inconsistency. When you distract the patient, the movements changes or the weakness changes. Incongruent is another complicated thing where whatever you see doesn't fit into a clinical diagnosis or doesn't fit into a particular neuroanatomical damage or disturbance. So again, you need to have real thinking behind it to apply these two. So though they are considered to be two pillars in diagnosis, usefulness is a bit limited. Now, what is pathophysiology? I mean, God only knows probably the best answer. But the current thinking is that there is an evidence of brain dysfunction. In this conference, they were talking about agency. Agency, in their words, is actually loss of control. So we all believe, our brain believes that every brain has got control over every movement. And they uses that with a feed forward or feedback loops. So whenever the premotor cortex think about a movement, it sends an information to the motor cortex for the movement, and also a center in temporoparietal junction where there is actually there's a control. So they send the information to the motor cortex as well as to the control center, which is temporoparietal junction. And when a movement is, so when you try to bend your elbow, when a movement happens, actually there is a feedback loop goes into this control center. And there is a mismatch between the feed forward and feedback loop, and the brain gets confused. That's one of the theory behind it. And the other theory is that the issue with sensory processing. The sensory processing become very slow. So one of the things you see that when you see in this, not the elevator, the escalators. So have you ever tried to climb an escalator which is actually not working? A lot of people feel that it's actually a quite complex feeling because you actually in your mind, that escalator is moving. The brain thinks that escalator is moving and that doesn't get enough, so that your feedback, the visual feedback is quite slow. So a lot of people actually in the first few steps, they find quite weird and then you get adjusted to it. So it's something similar phenomenon that what they are talking about. And then they talk about this predictive coding. So now everything is, because we know that there are a lot of different circuits around, and the brain predict each of those movements. And when it doesn't happen the way it's supposed to be, the brain gets very confused. So, and that's controlled by our belief system, that's controlled by our previous experiences and all those things. And then they're talking about this amygdala limbic system interactions and some structural changes. And fMRI studies have shown some functional changes. So there's a lot of work going on it, but nothing is very clear here. It is functional. Now, when you formulate a diagnosis, this is used in many, like a biopsychosocial formulation of a disease. You look at predisposing, precipitating, and perpetuating causes. So predisposing is risk factors, precipitating is triggering factors, and perpetuating is maintaining. So what is maintaining this disease? So you can actually put these different reasons. So you can actually, this is quite useful when you're trying to formulate a diagnosis and a treatment option for many chronic diseases, including functional neurological diseases. If you try to formulate a treatment plan for chronic pain, this is quite useful. Now, how do you diagnose this? So you look at this, you take the history in classical medicine, take the history, look at the symptoms, what are the symptoms, when did the symptom happen, how did the symptom progress. I always ask the patient to describe their typical day, which actually will tell me a lot of things. What is their disability associated with this illness, whether they are really depressed, whether they are active in the society, whether they're talking to people. Look at the dissociative symptom, depersonalization or derealization. Depersonalization is not, they think that there are certain parts of their body is not theirs. Derealization is they sort of They are not belong to the surroundings. Always, if a person has got movement disorder or seizures, videos are very useful. We always tell the family to take videos. Always wanted to know what is their idea about their illness, what their expectations are. I always try to initiate a discussion with whether they have any stress, whether they have any significant life event. I don't really go into it because it's quite personal to a lot of people. And I don't have a lot of those very good interaction at the first visit. So I'll try to develop a rapport and then ask those questions in the subsequent visit. The most important thing about treating a functional neurological disorder is that first interaction. Because these people have gone to different people, and most of these people will tell you that they went to see a doctor completely dismissive. They don't really engage. They said, you don't have illness, go away. And the first interaction is the most important to keep that therapeutic relationship. So I try to avoid asking complicated questions, try to be as simple as possible. But then when we get chance, we can ask more questions. Examination. So there are diagnostic signs, functional limb weakness. You can use Hoover sign. It's been there for many, many years. It is sensitive, but not very specific. So basically, you have hip extension weakness. So you can do it in sitting or lying down. Hip extension weakness. So when you test the hip extension, it is weak, but we ask the person to lift the other leg against resistance, and then hip extension weakness improved. Similarly, there's a hip abductor sign. The hip abductors are weak on one side, but we try to activate the other hip abductors. This abductor weakness improves. Then functional neurological disorders, usually functional dystonia. It usually comes as a very fixed sort of postures. And as you know, traditionally, dystonia is not fixed. It's variable. There is an amount of co-contraction. So when you see something fixed, it is functional dystonia. Then functional facial dystonia comes with certain muscle sort of, it may present like a facial weakness, but it doesn't have all features of a facial weakness. Then functional tremors, the classically something they call entrains. That means that you ask the person, so if you've got somebody has got a left hand tremors, they actually ask the person to so you show them some movements. Most of the time we show a movement like this, and the person, you ask the person to actually do it with their right hand, which is non-involved hand, and then slowly, when you distract, these tremors will reduce. And a lot of time it stops, or it takes the same movements as the other hand. So it's called entrainment. Then seizures, lot of time. I mean, the thing is that if you try to treat a functional neurological disorder, where especially the person present with weakness or pain, they may also have seizures. And when they are in therapy, sometimes they have a seizure-like event, and then everybody is so worried about it. So you need to know about functional seizures, even if you are not treating seizures. So most of the time, the issues are the prolonged seizure. The seizure lasts for more than 2 minutes. Eyes are closed, eyes are tight. You can't open their eyes. And then side-to-side head shaking, hyperventilating, and they continue to have normal saturation. So normally when people have got seizures, the saturation drops. So they continue to have normal saturation, they hyperventilate. They're supposed to be very good sign to differentiate functional seizures from normal seizures. Functional visual loss, and the visual field deficit at 50 centimeters and 150 centimeters remain same. They're called something like a tubular vision. As you know, normal vision, if you look at the visual field from a shorter distance and a longer distance, visual fields are a lot bigger from a longer distance because of the conical visual fields. And then visual fields, you keep on assessing, they become smaller and smaller. Investigation, so functional disorders, you can have associated neurological disorders like multiple sclerosis, Parkinson's disease. So you need to be aware of that. Imaging studies is important, but make sure that you're not over-investigating. You don't investigate for rare disorders. That's something we see with a lot of people. They're having MRIs after MRIs after MRIs. If you have done an MRI, no point in doing another MRI. It's not going to show anything different. Some of these people has got vitamin deficiency, B12 deficiency. The other thing I see, a lot of these people have got thyroid, hypothyroidism. So we just have to make sure that you do appropriate bloods. Video EEG is useful for functional seizures. One thing you have to be careful. When we do scan, we see a lot of things, and most of them are called incidental finding. Don't hang on to those incidental findings. That's another thing. That is something in your brain. That will be completely normal. So diagnosis. So it's a functional related to function of the nervous system. I usually use the software-hardware issue thing. There's no problem with the hardware, but there is a problem with software. It is a clinical diagnosis. It used to be a diagnosis of exclusion before, not anymore. We have to consider functional neurological disease first and foremost in your diagnostic formulation. And based on positive clinical findings, inconsistent signs in examination and functional presentations. Other condition to consider. It has been described in literature but have not really seen. So factitious disorder, or olden terms called Munchausen syndrome, or malingering. They are patients deliberately making sure that they have an illness or they have a weakness. The difference is that factitious disorder, there's an internal gain. Malingering, there is an external gain. So malingering, history is inconsistent. Usually the patient were presented before with the similar symptoms. They don't really want to do any tests because they don't want to know. Inconsistency, they try as their best to get the symptoms as close to the normal disease as possible. Usually you see a medical, legal, or some other external gain. Misdiagnosis, need to be careful. I mean, I was talking about the diagnosis is very important, and this year, the Patient Safety Day, that is the most important thing. You have to be careful here. Yeah, so most of the time, these people, we need to actually, if you are not sure, we need to get a colleague's opinion, a neurology opinion, or something like that. So sometimes functional neurological disorders are not diagnosed. They're diagnosed as some other illness, like most common is multiple sclerosis. Sometimes, you diagnose functional neurological disorder, but it is not functional neurological disorder. So you need to be careful in both ways. So how do you explain? That's another important thing. You have to be factual, but you have to be empathetic to the patient. Because it is a complicated thing for the patient, because you always think that you have a problem because you have something in your brain or somewhere. When you hear that I can't see anything, it is difficult for you to explain, but it's a very difficult thing for patient to hear also. So you have to be careful here. So I would always go, you have a functional neurological disorder, and I will tell them why I made that diagnosis. I show them some of those positive signs. I also clearly say, in my opinion, you don't have multiple sclerosis, you don't have Parkinson's disease. I always talk about this is a functional problem. This is how the brain communicates. I always talk about the hardware, software issues. You have hardware is normal, your brain is normal, but the software issue is not communicating well. It is not an uncommon disease, and we have treated so many people. Recovery is possible, but it involves a lot of work. I would always give them some information, but what information you give, you need to be careful, because there are a lot of internet information, Google Doctor, which actually gives them more alarming information. So you need to be careful. So I always give them some printouts. And again, I told you, this is not an easy diagnosis for the patient and their family. So you have to be empathetic. And when you're informing the patient, one size doesn't fit, Software with hardware, computer thing works with a lot of people. Sometimes you have to actually talk about this attention, nervous system overload, and all those things. Automatic motor processing, motor learning, all those things are useful. But you have to actually tailor to what the patient wants. Before rehab, we have to make sure that we confirm and discuss the diagnosis. We cannot start rehab unless the patient accepts the diagnosis. Sometimes the patient accepts, the family don't accept. So we have to work hard for the patient and family to accept the diagnosis. We have to make sure that some of these people have got psychological comorbidities. We have to make sure that if they have depression, PTSD, we actually have appropriate treatment for that. We have to assess whether they are ready to have rehab. Treatment options, there are a lot of treatment options. You have education, which is one of the cornerstone, movement retraining, developing a self-management plan, cognitive behavioral therapy, multidisciplinary therapy. All those things has got evidences. Not everything fit for a patient, so you have to be careful in what we take. When you look at treatment, there are two types of FNDs we look at. One is you have symptoms and then goes on. The other one, episodic. So you have symptoms, it improves, comes back again. So you have treatment options depends on that situation. When you have episodic FND, one of the things you look at is that, especially when they have functional seizures, how to terminate that seizure attacks. There's a treatment option looking at the window of tolerance. So hyperarousal, the window of tolerance become less. Hyperarousal, window of tolerance actually improves. So there are a lot of some literature available for this. So treatment. So when you're treating, you actually treat based on 3 or 4 current symptoms, because some of these people have got multiple symptoms. We also understand what they have tried before, because that is very important. If that's something which has not worked before, there's no point in doing that. We developed, there was talk about goal settings. We developed 3 or 4 functional goals. I would not force on treating psychological comorbidities when we start treatment, but as I go forward, I will be looking at that. I won't rush things. I will go slow with them, trying to make them understand and then take them along. Some of these people are very suggestible, so you just have to be careful in what prognosis when you give them the prognosis that everything will be all right in 2 months, they will be holding on to it. Self-management concept is important. Strategies to facilitate patient control is very important. So treatment, so grounding exercises, like there are a lot of different grounding activities. You can actually Google it and you can see. I don't have time to explain further. Controlled breathing exercises, again available, you Google it. Be creative with communication, patient with communication deficit. Make therapy interesting, sort of unpredictable therapy options. Telehealth is useful. Videos before and after treatment. Talk about how, not why. Why is not a very good word. It's good to investigate something, but talking to the patient why is not. Talk about how. Yeah, so make sure that you manage stress, reinforce, making sure that the patient, you are not at fault. To avoid, you should not use adaptive aids. You should not try compensatory strategies. I would avoid using orthotic or splint, because patient will become, so when you have a splint, you're more attentive towards it and you're overemphasizing impairment. We don't want to do that. Just 2 minutes about non-epileptic seizures. Non-epileptic seizures, they are like seizures. They are hard to manage. We just have to understand what is the trigger. Usually they say they feel pretty bad before they have one of those episodes. Some of them have triggers. So usually they happen in a very safe place. They don't, most of the time they don't happen when the patient is standing. They will happen when the patient is sitting. I've not seen anybody having a seizure when they were driving, but normal seizures can happen in all scenarios. Eyes are very shut, they're resistant to opening, they shake all their limbs, hyperventilate, longer duration. Now, how you treat that? So prodromal, stop and reset, ask the patient to do, sort of distract the patient, grounding exercises, putting some water onto their face is a grounding exercise, I say. Put them make them lie on the ground. During the seizures, ensure that they are safe. If they are sitting, make them lie down. After, talk to the patient, reflect on what happened, because most of these patients don't remember what has really happened during the seizures. So reflect on it, implement strategies to prevent further attacks. Relapse prevention is very important. Most important is developing a self-management plan. So that's it. Hope I've given you some information about functional neurological disorder. It's an area I would like rehab people to get involved, and it's a rewarding area if you work with these people. It's hard, but it's a rewarding area. There are a lot of opportunities in this space. Thank you.
Not a question, but I frequently treat these conditions. I use an intervention called neural therapy. We inject autonomic ganglia. I'll talk about it tomorrow in my pelvic floor talk, but nice talk, thank you.